In this video section, we will discuss about the external abdominal hernia. So let's revise the little bit anatomy of the abdomens. There are the four quadrants: right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant, and 9 regions. So like epigastric region, and the right hypochondric region, left hypochondric region, umbilical region, left lumbar region, and the right lumbar region, and the hypogastric region, and the left iliac and the right iliac. So let's discuss external abdominal hernia. So definition is the external abdominal hernia occurs when abdominal organs or tissues leave their normal anatomic site and protrude outside skin through the congenital or acquired weakness. Defects are holes on the abdominal wall, including inguinal hernia, umbilical hernia, femoral hernia, and so on. So what the classification? Classification in epigastric hernia, incisional hernia, spigelian hernia, umbilical hernia, and the femoral hernia. Let's discuss one by one. So epigastric hernia occurs when a weakened area in the abdominal wall shows the bit of the fat to push through. And epigastric hernia are typically small. They occur in the middle of the belly. In the area between the belly button and the breastbone, some patients develop more than one epigastric hernia at a time. These hernias typically don't cause symptoms but may experience pain in the upper belly. In the incisional hernia, a hernia that occurs in the area of the previous surgery is also known as the incisional hernia. These hernia may occur when the abdominal wall has been weakened by surgery or when a surgical incision becomes infected, further weakening the area. In the incisional hernia, the relatively common because surgical incision weaken the abdominal area that weakens the weakness makes it easier for a part of the intestine or other tissue to the protrude. Incisional hernia can develop soon after the surgery, or they can develop slowly over months or even years. They typically occur alongside vertical incisions, and the incision hernias tend to be large and rather painful. So here you can see this the incisional hernia. Next is the spigelian hernia. Spigelian hernia occurs throughout the spigelian fascia. Unlike other types of the hernias, which develop immediately below layers of the fat, spigelian hernias occur in the midst of the abdominal muscles. This means that spigelian hernia may not be immediately visible as a bulge or the lump. They can go undetected for the longer period of the times because spigelian hernias tend to be small. The risk of the developing is strangulated hernia is higher. So here you can see the spigelian hernia. So next is the umbilical hernia. Umbilical hernia occurs when a weak spot in the belly allows a big bit of the fat, fluid, or intestine to push through and creating a lump or the bulge near the belly button. And the umbilical hernias frequently occurs in the infants. In most cases, these hernias will heal on their own. Occasionally, however, surgery may be required. Umbilical hernia also occur in the adults, and particularly those with the health issues that cause the increased pressure in the belly. Those issues may include obesity and the pregnancy, chronic coughing, and the constipation and difficulty urinating because they tend to grow bigger over time. Umbilical hernias require treatment. Treatment typically involves surgery, but doctor will discuss all the options with in detail. And without treatment, at risk of the developing strangulated hernia, which means that the blood supply to the tissue has been cut off, and strangulation is the life threatening and requires emergency surgery. So here the umbilical hernia. Next, femoral hernia is a rare type of hernia. Femoral hernia sometimes appear a painful lump in the inner upper part of the thigh or the groin. The lump can often be pushed back in, or it disappears when lie down. And the coughing or the straining may make the lump appear. A femoral hernia usually occurs when a fatty tissue or a part of bowel pokes through into groin at the top of the your inner thigh. It pushes through a weak spot in the surrounding muscle wall, abdominal wall, into the area called the femoral canal. Unlike the inguinal hernias, femoral hernias are far more common in women, particularly older women. This is because of the wider shape of the female pelvis. So Femoral hernias are rare in children. Femoral hernias can sometimes appear suddenly because of the strain on the tummy, such as the straining on the toilet if you have constipations and the carrying and pushing heavy loads. So here you can see the femoral hernia. This is the physical appearance. So next is the physical examination. In general, the physical examination should be performed with the patient in a both supine and standing position with and without the Valsalva manual. The examiner should attempt to identify the hernia sac as well as the fascia defect through which it is the protruding. This allows proper direction of the pressure of the reduction of the hernia contents. The examiner should also identify evidence of obstruction and the strangulation. The first step in attempting to identify a hernia is to look for the swelling or the mass in the area of the facial defect. A fingertip is placed into the scrotal sac and advanced upward into the inguinal canal. If the hernia is elsewhere on the abdomen, an attempt should be made to define the borders of the facial defect. So, if the hernia comes from the superior lateral to inferior medial and strike the distal tip of the finger, it most likely an indirect hernia. If the hernia strikes the pad of the finger from deep to superficial, it is a more likely to be direct hernia. A bulge felt below the inguinal ligament is consistent with the femoral hernia. Strangulated hernia are differentiated from incarcerated hernia by the following: the pain out of the proportion to examination findings, fever or the toxic appearance, and the pain that persists after reduction of the hernia. So causes: abdominal wall hernias can occur in the people of any age, including infants. However, the risk of the developing hernia tends to increase as you age. The most abdominal wall hernia are caused by area of the weakness in the abdominal walls. A number of the different factors can contribute to the development of that weakness. These factors include aging, chronic cough, and the collagen vascular disease, frequent heavy lifting, genetic defects, and history of previous hernias, infection, especially following surgery, injuries to the abdominal area, and obesity, and the pregnancy, straining during the bowel movements or urination, surgical openings. So next, the diagnosis: identification of incarcerated hernia site. Incarcerated hernia is mainly characterized by tenderness at the incarcerated site, followed by whole abdominal pain, bloating, nausea, vomiting, intestinal obstruction, such as the absence of the bowel movements. The development of the disease course is a key aspect during the collection of the medical history. In the full exposure of the abdomen is required during the physical examination, especially the bilateral inguinal hernia, to rule out the incarcerated inguinal hernia. It should be noted that in cases of the incarcerated femoral hernia, the small size and the thick abdominal wall fat can make the lesion hardly palpable, leading to the misdiagnosis. So treatment for the incarcerated hernia is often delayed in elderly patients due to the unresponsiveness and the intensive insensitivity to the local pain, with the abdominal pain, bloating, nausea, vomiting, and intestinal obstruction symptoms being the only clinical manifestation. In this case, condition can be easily misdiagnosed as a general acute intestinal obstruction due to the hardness of the hernial ring. Umbilical hernia is a likely to be incarcerated. In the case of the obturator hernia content penetrate through the obturator tube from the hip, so the mass is not easily noticeable on the face and may lead to the difficulty diagnosis. The focus of examination should include hernia, inner thigh pain, and the history of the inability to strengthen the thigh, as well as the unique owl shape and the rhombic syndrome of the obturator hernia, and tingling pain of the inner thigh, symptoms caused by the compression of obturator nerve by hernia content radiating to the popliteal and knee area and accompanied by the paresthesia. Palpable cords of the incarcerated hernia can be noticed in the transrectal and transvaginal pelvic digital examination with a significant tenderness. So, identification of the presence of incarcerated hernia associated with a poor prognosis, and it should be thus suspected with any of the following clinical manifestations, like severe abdominal pain with a persistent pain during the inter periods of the proximal pain, and the gradually increased shock, and evident peritoneal irritation, and increase the body temperature, pulse rate, and the white blood cell count. The bloody fluid in the vomit or intestinal excreta are from the abdominal puncture, and the asymmetrical bloating palpable and the tender intestinal loops with the rebound tenderness. So here you can see the transrectal and the transvaginal pelvic um, examination of obturator nerve. So next is the supplementary examinations X-ray curve. Upright or lateral abdominal plane. Films often show a bowel dilatation, multiple air fluid levels or other characteristics finding related to the intestinal obstructions. So here you can see that abdominal hernia with the obstructed small bowel lobes. So next is the ultrasound. This often shows the expansion of the intestine with the reverse peristalsis or the affixed massive without the peristalsis or expansion of the fluid filled bowel. Intestinal fluid reflux and thickening and edema of the intestinal wall can be observed, as well as the slightly echogenic long strip shaped omentum in the hernia sac. The occurrence of hernia incarceration can be determined by observation of the blood supply in the hernia content with the color Doppler ultrasound. So here you can see that the defect in the incisional hernia ultrasound. So next is the CT scan by the bowel dilation, the mesangial thickening, and the other signs can be observed as abdominal wall defects. And CT scan follow oral iodinated contrast is the more conductive to determining the whether the content in the sac or intestinal, and if so the intestinal type. Enhanced scans can be help identify the presence of the bowel strangulation for incarcerated hernia with a smaller abdominal wall defects and especially femoral and obturator hernia that difficult to diagnose. And CT has its important clinical value and the soft tissue signal seen between the pubic muscles and the obturator muscle. Upper and the lower bundles of the external obturator muscle or the internal external obturator muscle on the pelvic CT support the diagnosis of the obturator nerve. So here you can see the CT scan. So next is the treatment. In treatment, in attempting the hernia reduction, the first step is to provide adequate sedation and analgesia so as to prevent the straining or the pain. The patient should be relaxed enough that he or she will not increase the intra-abdominal pressure or tighten the involved musculature. The patient should be spine with a pillow under the knees. For inguinal hernia, the patient should be placed in a Trendelenburg position of approximately 15 to 20 degree, and the ipsilateral leg is placed and externally rotated in the flexed position resembling unilateral frog leg position, and the padded cold pack may be applied to the area to reduce the swelling and the blood flow while the appropriate analgesia is established. Ice cooling of the incarcerated hernia is counterproductive. Then the simple pressure over the distal sac usually ineffective in that the incarcerated viscera are like to mushrooms over the external ring, and instead the two fingers are placed at the edge of the hernial ring and firm, and the steady pressure is applied to the side of the hernia content close to the hernia opening and maintained for the several minutes while the hernia is being guided back through the defect. So here's the hernia reduction. In children, pressure should be applied from the posterior directed laterally and the superiorly through the external ring. It should be kept in the mind that the internal ring in the infants is more medial than the internal ring in older children and adults. The hourglass configuration of the hernia hydrocele complex will not reduce the pressure applied to the hydrocele portion. If the success is not achieved after one or two attempts at reduction, a surgeon should be consulted. Repeated forceful attempts are contraindicated. Pain after a successful reduction may indicate a strangulated hernia necessitating further evaluation by a surgeon. The spontaneous reduction technique requires the adequate sedation and the analgesia. In Trendelenburg positioning and the padded cold packs applied to the hernia for the 20 to 30 minutes, this can be attempted before manual reduction attempts. So here you can see the hernia reduction. In this figure, hernia content balloons over the external ring when a reduction is attempted, but here can be reduced by the medial pressure applied first. So topical therapy cauterization with a silver nitrate aids in the resolution of umbilical granuloma. If there is a stalk and the ligation of the base resolve the problem, delaying the repair of the umbilical is symptomatic, and the epigastric hernia until the children are older than 5 years allows the spontaneous clear in the most children. Strapping with or without the coin is not indicated in the treatment of the umbilical hernia because of the problems with the skin erosion and the lack of the effectiveness. Grob introduced the use of the mirbromin as the escharotic for the scarifying the intact scag of the giant amphilocyl. However, the development of the mercury poisoning terminated its use, and chemical dressing using silver sulfur diazine, which has the leukopenia as a complication. Povidone iodine solution, hypothyroidism as a complication, 0.5% silver nitrate solution, ergorism as complication, and then genti and violet have served as an agent to protect the against infection while the sac epithelializes. So this is the again the topical therapy. So next for the preparation for the surgery, aspirin and Plavix slow down clotting factor. In general, these medications are stopped 7 days prior to the procedure to decrease the risk of the bleeding. Comidine also shows a down blood clotting and should be stopped at least 3 to 5 days prior to the surgery. It is extremely important to discuss these medications with the doctors, as stopping these medications without the substitution or the medicines may be dangerous in certain situations. Fasting is required overnight prior to morning surgeries, or at least 6 hours prior to afternoon or evening procedure. All daily medication that doctor instructs the patient to the continue can be taken on the day of the surgery with a sip of the water. The next is the surgery open technique. The open technique is the traditional approach that people think of when imaging surgery. An incision is made in the skin near the hernia, and the intestine or the fat producing through the muscle is reduced into the abdomen. The defect in the abdominal wall is then repaired through the incision, and skin is closed over the repair. There are the two options for repairing the defect with the open technique. The first use only sutures to bring the muscles and the connective tissue back together. For large hernias, this can create the tension in the repairs, which contribute to a failed repair and return of the hernia known as the recurrence. Next is mesh is a soft and a flexible woven plastic like material that has been used to repair hernia since the 1950s. The use of the mesh has greatly reduce the rate of the recurrence in all hernia repairs. Some surgeons recommend the using the mesh for all umbilical hernia repairs, and others only recommend its use in the larger defects. And so we typically use mesh in large defects, or those that appear as they may have higher risk of the recurrence. There are many types of the mesh, and most are well accepted by the body and allow the natural tissue to grow into them. They are used to reinforce the clear of the umbilical defect. The discussion with the surgeon can help the patient decide if the mesh is necessary, what type is most appropriate. So here you can see the external oblique and the PHS final position and the pubic tubercle stages. So next is the surgery laparoscopic technique. Laparoscopic and minimally invasive surgery is another hernia repair option. During the laparoscopic surgery, 3 to 4 small incisions are made in different parts of the abdomen, so that the specialized long thin instrument and video camera can be inserted. The abdomen is temporarily inflated with a gas to give the surgeon space to work under the abdominal wall. So that's it.